So here's a really quick guide for comprehensive review, like a quick super review of cardiac system. And this is just generalized things that I've noticed that need to come up often. And I think that this would be good all around the board for everybody for a quick reference guide. It's only about 30 minutes. I think it's perfect. So give it a go and let it roll. All right, when we are assessing cardiovascular systems, we need to understand that systole represents the ventricular contraction and ejection of the heart muscle. We call this the contraction phase. So systolic dysfunction means that you're going to have a problem with contraction of the heart muscle, right? Also, in the elderly, if you recall from last examination, increased systolic blood pressure, that is an age-related change specific to systole and its function of contraction of the heart muscle. Diastole is going to represent ventricular filling, also relaxes the heart muscle. We call that the relaxation phase. And very simply put, diastolic dysfunction is going to be a problem with the relaxation of your heart muscles. So recalling what we just talked about, systolic pressure is going to be on the rise when we're dealing with patients who are elderly. Elderly patients have to have a little extra time and attention when they're moving around, when they're responding to things like healing, exercise, stress, recovery from activity. These are all going to be issues with them. So they are most certainly going to have at some point in their life as they age, a period of having orthostasis or orthostatic hypotension, which is where they stand up too fast and their heart can't catch up. So we are going to encourage them and educate them to sit and dangle to prevent those things. When you are waking up in the morning, make sure that you take slow movements while you're sitting up, while you're rolling kind of your feet over to the side of the bed type of a deal. Otherwise, they get orthostasis, fall, have a hemorrhage, and then things go really, really wrong for them. So when we're dealing with assessment of cardiovascular systems specific to sounds, there's going to be a couple of issues that could arise. We could have an arterial bruit. Sounds like a shoo, 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 like a whooshing, like water rushing through a fast river. It's going to tell us that there's something in the way. So it implies stenosis or a problem with an occlusive issue that is proximal to the patient, so anything above that level. Heart murmur is more of a blowing or rasping sound. You can give it a Google if you're curious what that sounds like. Most murmurs aren't a big deal. They're benign. Some of them are kind of a big deal after all. So it's kind of a rough, turbulent flow that goes through the heart valves or near the heart. Depending on where you hear it, it's going to depend on what type of murmur it is, which depends on how big of a deal it is. Recall, things that happen in the ventricular region are much more imperative to the body system than things that are going to be up higher, because those are the lazier areas of the heart. Think about what we talked about with the mom who is dropping down the laundry to the kids downstairs. Her job is very minimal. So issues in that part of the heart are not going to be that big of a deal versus something that would affect one of maybe the kids who are aerating the laundry through drying it and then walking it back upstairs, which would represent our left ventricle, which is a big deal because then it circulates it through the whole body, right? Pericardial friction rub, that's going to be a high-pitched scratching sound during S1 and S2. It indicates pericarditis. We need to make sure that the patient is leaning forward and holding their breath at the end of the expiration, because remember, that's like somebody slamming on brakes and that seatbelt grabbing us and squeezing us. It's that same type of effect. It's going to put a lot of pressure on that area so we can hear it really well. All right, so when we're talking about high risk for cardiovascular disease, having a higher LDL is a big problem. LDL is low density protein or lipoprotein, but we know it is lethal because it's easier to remember. High density lipoprotein, we want that a high level because that is a healthy level. And that's basically all that you need to know about that for the purposes of this class, at least. The lethal or LDL can result in atherosclerosis, plaque buildup. It's a big deal. HDL is healthy and it's good because it can be removed from the bloodstream because it's excreted through your liver, whereas the lethal stuff can't. So it basically goes directly to the arteries, which is why we have the problems that we have. So again, assessment of cardiovascular systems very quickly. We have a picture in the cartoon in our head of mom doing laundry and she's throwing it downstairs. So blood comes into the right atrium from the body. That would represent mom filling that basket before she walks it over to drop it. Once the blood comes into the right atrium from the body, then it moves to the right ventricle and is pushed into the pulmonary arteries in the lungs. That would represent mom dropping the basket to the kids walking it to the washing machine and getting prepared to put it into the dryer, which is going to go from our deoxygenated blood that flows from the lungs to the right ventricle. Right? That is the process of quote unquote washing it and preparing it to be aerated and throwing it into the dryer, which gives us that nice oxygenated blood. Now, after we pick up that oxygen, we then travel back to the heart through the pulmonary veins to the left atrium. This would be the kids walking up the stairs with the basket of laundry that is aerated and quote unquote oxygenated. And then finally, the blood moves to the left ventricle out of the body's tissues through the aorta, which would represent mom grabbing that basket and distributing it to all of the kids' bedrooms. Okay, aka distributing all that blood to all of the tissues via the left ventricle. So make sure that you understand all those. Now, assessment of cardiovascular systems related to troponin. Troponin is a type of protein. It's found in the muscles in your heart. So I want you to think about walking around eating chips. You're walking around eating chips and maybe you're not paying attention, so it's going to drop things onto the floor. So troponin isn't normally found in the blood, but when we start to break apart heart muscles, they become damaged. It's like eating chips and walking across a carpet. You are going to drop bits and bobs of those chips into your bloodstream, if you will, which would then regulate through a lab level known as your troponin I. So as the damage increases, the more chips you drop onto the floor, which means the higher level of troponin that you're going to have. So it's going to be indicative of a myocardial infarct or a heart attack if you check your troponin level and you see things over a level of like 28. Usually it's 0.40 or above, or 0.10 or above, depending on what hospital you're in. But right when we get around the levels of 25 and higher is when we go, okay, this is definitely an MI and it's complex. Okay, so just understand a lot of things can contribute to a troponin level being elevated: sickness, COVID, all of these things. That would be a troponin T versus a troponin I. I don't need to get into the schematics of all of it, but I will tell you that a troponin I level of the 20s or higher is going to be independently predictive of a cardiovascular mortality, which means your heart is dying effectively, versus someone who has a lower level, which might be what they considered an NSTEMI, right? Which is kind of a heart attack, sure, but it's the one that we can definitely recover from to some capacity. So please understand your levels, what it does, how it works, right? And know that that's the diagnostic lab that we are going to use to confirm a suspicion of that infarct. Okay, so the GI system and the cholecystectomy. So cholecyst means gallbladder, ectomy, or ectomy itself means removal of, take it out. So we're removing the gallbladder. It's going to relieve gallstones, gallbladder pain. It's going to help with things in the bile duct. The long-term effects of it, we're going to get diarrhea right after we eat, fatty food intolerance, right? So cheeseburgers are a no-no, or you're going to have to go straight to the bathroom. You might get nauseous, you might vomit, you might get yellow, you might have issues of abdominal pain. This can happen for years after surgery. So please understand your side effects. Please understand what it is, why we're doing it, and what the expectation is as well. So here are your abdominal quadrants. I felt like we needed to do a review over these. So here's literally every piece of your body and what quadrant it falls into. You're going to be asked a question. Hey, what patient dysfunction is this patient going to have if there is dysfunction in the left lower quadrant? So you need to be able to go left lower quadrant. That's the left ureter and reproductive organs and sigmoid colon. Okay, got it. Right? I'm not going to make it too terribly difficult, but please know what quadrant goes where and what pieces and parts go where. All right, so liver failure. Liver failure can be fast or it can be chronic. It can be acute or chronic. Reaction to medications can cause it. High doses of acetaminophen over 4 grams. Hepatitis infection, alcohol abuse for sure, advanced fatty liver disease, that could be through NASH, which is non-alcoholic liver failure, jaundice, the yellow eyes, belly pain, huge symptoms, okay? So what lab values are going to be associated with liver failure? Well, bilirubin is going to be a big one, but more importantly, we do ASTs and ALTs because that's going to let us know cirrhosis or hepatitis specifically. ALT is usually our go-to. AST is our secondary. So just understand liver failure, what it is, what it causes, what it looks like, and what labs. All right, enlarged prostate. So enlarged prostate means the prostate gland is too big. So it is pressing down on your ability to pee via the ureter. And it is called BPH sometimes. Sometimes you have to have a procedure where they remove that. And then you have to have a tube that goes in your penis and basically flushes out that system. It's called a TURP procedure. You don't need to worry about it right this second, but you will hear it for your next classes. So symptoms associated with that. It is difficulty to start peeing, basically. Straining to pee. Having a low flow of urine. The starting to pee. The dribbling to pee. The urgency and frequency. So basically, with enlarged prostates, we need to know what's going to be the telltale signs of it, and what could it possibly be, and what causes it, and you should be good. All right, so terms related to urinary volume. Very simply put, you're going to need to know these. This is the average daily urine output. This is the normal daily range for urine output. This is what polyuria is considered. This is what oliguria is considered, inuria, nocturia, and also know that it is normal to urinate on nights on occasion. It is, normal to urinate large amounts when you consume a lot of fluids. It's normal to have urine free of ketones and glucose and bilirubin. And any of the, big ones that don't have those key components in there, right? So like if I'm oliguric, incredibly low amounts of urine, that's a problem. Anuric, that's even a bigger problem. We're talking about dialysis patients. So know your definitions, know what it means, know what the volume means, and you should be good to go. Now, when we're dealing with urinary systems, we do lab levels. One of them is a BUN, or what they call a blood urea nitrogen measurement. It lets us know how much urea nitrogen is found in the blood. It's a waste product when your liver breaks down proteins. It's carried in your blood, filtered through your kidneys, and supposed to be removed from your body. So normal BUN level is 7 to 20. And when we're dealing with elevated dehydration, heart failure, or GI bleeding, you're going to deal with elevation of the function of your BUN levels. So there is one caveat to this. You can have a patient who is ridiculously hydrated, okay? And it's not going to necessarily mess with your BUN levels that much. So if we know that a patient is, a bodybuilder, so they drink a ridiculous amount of water, like even up to 100 ounces a day, you're still going to have a maybe lower range, but otherwise a normal BUN, and I would expect your urine to be pale, or pale yellow or clear. So please understand that your urine color is going to directly affect your hydration status, and specific to your BUN levels, it is not going to necessarily affect your BUN in a negative way if you drink too much water, unless there's an absolute dysfunction. All right, this RAS system is very complicated. I've been racking my brain all day long to try to figure out how to explain to you the RAS system, and I kind of have an idea, but I'm still not 100% sold on it. So I'm going to give you the best depiction of a RAS system that I can come up with in less than 2.5 minutes, And I'm going to teach you the key points here that you need to pay attention to. I want you to read these things and try to understand it, but I understand that it's very hard to understand the complexities of the RAS system, even in an entire semester, because the RAS system is nearly as complicated as sympathetic versus parasympathetic nervous system process, but also very important. So renin is released into your bloodstream in response to decreased blood pressure. The whole position of the RAS system is to increase your blood pressure. Please understand this. It is a result of your blood pressure being severely low and your body going, Mayday, we got to save this person's life immediately or they're going to die, right? So we use a couple of things. We start moving fluids around. We start moving salt around, right? We want to get a higher gradient of colloid to solute, more salt to water basically, and that will then drive your heart rate to tell your body to tell your blood pressure to rise basically. So what we need to know for the purposes of this class, and I will get into renin and I will get into the RAS system later, is that renin is released from your bloodstream in response to decreased renal perfusion or decreased arterial blood pressure. Okay, the plasma protein angiotensin is going to be from your liver, and it creates a byproduct basically that converts into a watered down version of itself and sends it and shoots it over to the blood vessels, also to the lungs, and stimulates the release of something called aldosterone from the adrenals in your kidneys. That causes you to have a salt dump and water retention, which increases your volume of your blood, which increases your ability to pump your heart better, okay? So I need for you to not freak out about all these things and all these pieces and parts. The way I look at it is the Mighty Morphin Power Rangers, right? They all have a piece and a part to them, but the leader is the White Ranger, right? Well, technically it was the Green Ranger if you do old things, but it was the White Ranger, right? Because or the Red Ranger, sorry. Red Ranger's the main guy. I didn't watch Power Rangers a lot. Big surprise. But it is the leader of the pack, leader of the football team, captain of the football team, whatever you want to call him. His job is to recognize that blood pressure is too low, and then he automatically pumps everybody up and gets them all hyped up so that they do their little piece and part that they need to do in order to morph together and get this person re-regulated, okay? But renin is going to be your captain of your football team, who is going to make sure that he moves all the players he needs to get the touchdown that they need. If that's the best way to explain it so that you can understand it, look at these guys as offensive line versus defensive line if you want. I'm going to find a clear way to explain it like I do when I do cardiac output and I explain that system by way of a mom doing laundry. I just haven't quite figured it out in my head how I'm going to do it and make sense of it to you guys. So I just need for you to focus on the hot spots that I'm talking about right now, and then I will get back to it later. All right, so nutrition, we need to know what a kilocalorie is. 1 calorie is basically a kilocalorie. It is that easy to remember. We're going to express it in 1,000 calorie mark, which is why we call it kilocalories, right? So when you ingest more kilocalories than a person has energy requirements for, you gain weight. And when you don't have enough kilocalories, when you have to meet the demands of the person, you lose weight. It's that simple. And that's all you really need to know as far as this nutritional concept of a kilocalorie is concerned. Now recall, when we're talking about nutrition and wounds, your body needs protein to repair those wounds. They provide an excellent source of energy. They promote growth and maintenance of your body tissues. So protein's also going to help fight infection because a protein molecule is much tougher to penetrate, right? So that it can't be sludged out by infection. It can't be penetrated by infection. Well, I mean, it can, but it takes a lot longer. It balances your body fluids because, again, that cell is really hard for anything to escape from or go into. Carries oxygen through your body. High protein diets are a big, big, big deal. So when you have wound healing, you got to look at food as medicine, specifically protein. All right, water soluble versus fat soluble items. You can read this. So I don't pay attention to which ones are water soluble. I pay attention to the ones that are fat soluble because there's only 4 of them, A, D, E, and K. right? Make up an acronym that'll work for you, that works fine. They're stored in fatty compartments of your body, so they hang around a lot longer. The caveat with this is you can get toxicity very easily. Water soluble vitamins, their caveat is they are absorbed easily from the GI tract to get what they need, so you have to constantly take them, okay? So it needs to be done through food intake or through medication intake. So if it's not A, D, E, and K, then it's water soluble. You have to have supplement and or nutritional changes that reflect and regulate those needs for those medications, which is why alcoholics have a problem with all of the water soluble vitamins, because alcoholics have frequent what? Diarrhea. There's your answer. So A, D, E, and K, fat soluble. The rest, water soluble. Fat soluble, you could get toxicity really quickly. Water soluble, you can have a deficiency of it very quickly. You have to have supplementation via food or nutritional supplement through pill or IV. All right, steroids and nutrition. This is very important. Steroids are going to strip you of all of the nutrients that you need. And this is why steroid therapy causes osteoporosis, because if you notice, we get rid of C and D. We get rid of potassium, sodium, proteins. We get rid of calcium, okay? So when we're dealing with this, we need to focus on low-calorie foods because steroids will give you extreme weight gain. Those are the things you need to have to take home. Tell your patient you need to avoid sodium. Don't eat processed can-packed foods. That's going to cause you nothing but trouble, okay? It's going to interfere with your nutritional absorption of sodium. So anything while you're taking steroids that is high in sodium, you're going to have too much of in this case, and that's why you have to stay away from it. Plus, it's going to cause you a milieu of other issues. So look for low sodium foods. Look for frozen fresh foods. Look for whole grain foods, things of that nature. All right, 7 types of urinary continence. You need to know all of them. I want you to read them and I want you to understand them. Make note cards if you need to, okay? Also know that urinary incontinence is different from urinary retention, which is the inability to empty the bladder partially or completely. I'm going to ask you, what is this an example of? And I'm going to give you a patient scenario. So you need to know what these are and what they mean. All right, Foley catheter care. Most important for Foley catheter care is we need to do daily checks for this because we can easily get a CAUTI, and that is a infection of you having a really nasty Foley that isn't getting cleaned like it's supposed to, right? So they're at high risk for acquiring this type of infection. You have to have more frequent perineal care, period, point, paragraph. That is going to fix this problem. You've got to have constant care. So read this slide, understand what it is, understand what type of patient will get it, and understand what fixes the problem. All right, intermittent catheters. Intermittent catheters are very important because it mimics the bladder starting and stopping like it's supposed to. This helps remind the patient how the bladder works again. So it also decreases the risk of infection. So we need to make sure that we are seeing what kind of patient we have, seeing if they are a good candidate for this, understanding what kind of patient needs to have this, right? So if you have bladder leakage, things of that nature, when you have a temporary urinary retention issue, when you have very high pressures that have developed into the bladder for occlusive purposes, right? Maybe we got a ureter stone or whatever is the issue. We have to have intermittent catheter. We're not going to stick a full-on Foley with them because we want their bladder to go back to basics. All right, bowel elimination and contributing factors. You need to know the contributing factors, and you need to know what fixes it. So diet, fluid intake, and physical activity are going to be actual proponents and issues related to the body's inability or ability to eliminate like they're supposed to. So please understand the contributing factors related to bowel elimination, which include age, infection, diet, fluid intake, physical activity, psychological factors, and personal habits. Okay, constipation. So here is a list of things that cause constipation. What are the take-home messages? Well, the take-home messages are pretty simple. All of those things contribute to it. Irregular bowel habits and ignoring the urge to defecate is a big one. So you can't walk a mile and not take a break. It's kind of a big deal. You can't over exercise in the gym and not take a break to relieve yourself, right? The number one way we need to educate our patient to relieve all the symptoms related to this issue is to increase your daily intake of water, right? It is going to give us more fluid to help move things along through peristalsis and to eliminate easier. When listening to your bowel sounds, we would expect that a person with constipation is going to have hypoactive bowel sounds. That makes sense. However, absent bowel sounds, we need to do a focused 5-minute assessment on each quadrant to make sure that we hear some type of gurgle, or they might have an emergency, which is an ileus, which is a immediate potential for surgical procedure. So read the slide, understand what's on it, move on. All right, dehydration in infants. These guys dehydrate very, very fast. They lose so much body fluid, they can't maintain their normal function, so they're going to be dry. They're going to have cracked lips or a wrinkled tongue. They're going to have rapid breathing. They're going to be listless, which means they're just kind of a zombie-like state. They really don't have any personality. They're just kind of there. They're going to have fewer wet diapers and they're going to cry less. So please understand those signs and symptoms related to dehydration in infants. All right, cardiac output, the amount of blood pumped through the heart in a minute, how it flows around the body. We need to know that it's based on stroke volume and heart rate. We need to know that tachycardia is a common sign of high cardiac output. Bradycardia is a common sign of low cardiac output, right? Makes sense. These are the things that contribute to tachycardia and bradycardia. When you have a patient who is hemorrhaging, for example, the stroke volume is going to be decreased and cardiac output is also going to be decreased. So what we need to do is increase that function by way of increasing the fluid volume with fluids. Similarly, tachycardia is common with a high cardiac output, so what we need to do is subside the tachycardia so that we could decrease that cardiac output and stop the tachycardia. So I think that's pretty self-explanatory. Understand the concepts, move on to your next slide. All right, so how to increase cardiac output. When you have a sustained heart rate that's in the 160s, we end up decreasing stroke volume and decreasing cardiac output because at this point we're just do. So we're barely even pewing this blood through the body system, through the arterioles, through the body's processing, okay? If you do it very quickly, that's one thing, right? That's going to be going low to high or high to low, which is going to be changing regulation. However, in this case, we've been doing it so often that we nearly have any stroke volume and cardiac output left because we're in overload. So what you have to do is you have to address the heart rate in order to increase the cardiac output and get a better stroke volume and get a better push, right? Because we're doing this. I want to do this. Do you see the difference in tympani? One's very low and dull, one's very high and forceful, okay? So please understand this concept and understand that when we have these issues, we need to increase the filling time, and we need to increase the stroke volume or the push to push that through so that we can get that heart rate to go down. All right, guys, we're almost done, and I still have 7 hours of teaching today, and my voice is nearly gone, so just bear with me. SA and AV node function. SA is the sinoatrial node. It sends an electrical impulse that goes to the upper chambers of the heart, allows them to contract. It's the pacemaker of and the powerhouse of the heart, basically, in the system. We usually pace at 60 to 100 beats per minute. And the AV node, or the atrioventricular node, does the lower heart chambers, right? The word ventricular is really in there, causing them to contract or pump. So what happens when we have SA dysfunction? Well, it's very simple. It goes into the backup system of the AV node, right? So after the SA node is dysfunction or has dysfunction, it goes to the AV node. It'll take over as the main pacemaker of the system, and it's functioning as well. Now, we're dealing with malnutrition in the elderly. There are very specific things that it could cause problems with. So they're going to be more vulnerable to infection. They're going to have slower recovery time, balance issues, falls related to dehydration. So what does that look like? Well, they're going to have dry skin, a lack of energy, a lack of muscle tone, pale conjunctiva, and brittle nails. Please understand what it means to be malnourished in the elderly. Please understand what it causes and what that can mean for the patient long term. Okay, so assessment of cardiovascular systems. What do we look like, or what do we look like when we're documenting a cardiac assessment? Well, the external chest is normal appearance without lifts, heaves, or thrills. Good. PMI, point of maximal impulse, is not visible. It's not palpate, or it is palpated in the fifth intercostal space, the midclavicular line, right? Which is where PMI is anyways. Heart rate and rhythm are normal. Apical pulse is da-da-da-da-da. Cap refill is yada-yada. Feet feel slightly cool. All those are fine. What are our abnormal findings? Well, everything that's under the thing that says abnormal findings in cardiovascular assessment. Please understand what that looks like. Please understand what that means to the body. And please understand that I'm going to ask you what dysfunction looks like in a cardiovascular assessment. Pretty simple. And then we can move on to the next slide. All right, going back to subjective and objective data. Subjective data is going to be anything that comes from the patient's opinion, right? It's going to be based on the quality of their work, right? I used it in terms for you guys because I feel like we're still having issues with it. So rather than putting it in a patient perspective, I put it in a student perspective. So that way you can kind of relate it to yourself and then relate it to yourself as a patient, and then you can tie the two together. So hopefully that helps you out a little bit. It's anything that you think. It's any opinion that is given. Like, I don't have a lot of sleep. Well, I literally don't have a lot of sleep. That could be objective data if I wrote it all down, but just my opinion of I don't have a lot of sleep is a subjective, right? It only becomes objective when I have it documented and it is coming from a professional, okay? So a sleep study person who says, yo, this girl don't sleep, and here's why, and here are the hours she sleeps, that's objective. If I say, man, I feel like I don't sleep a lot, well, you might sleep 16 hours, so there's that. So that would be subjective. Objective, again, is going to be anything that we could move, observe, obtain, find a numerical value for, et cetera, articulate. And that is from the professional's perspective. And finally, we are talking about post-surgical bowel perforation. This totally sucks. It doesn't happen often, but buddy, when it does, it is not a good day, and it never goes well, and it's always a problem. So it happens in procedure a lot of times. They accidentally snip something, nick something, cut something, and then obviously as things move down the pipeline, you have a slow leak, and then all of a sudden they start getting sick, and then all of a sudden they have this massive pain, massive severe abdominal pain, and that's about the point where we have physically escaped the intestinal area, and now we're just kind of hanging out in the wall of the abdominal space, and that's a bad day. Lots of things brewing and lots of things percolating, right? And oh yeah, you're also in a 101 degree fever. From the internal perspective, it's a little bit more, so that also really likes its best friend, bacteria and infection, right? So that's a bad day. And of course, their cousin sepsis. So chills, yeah, I can imagine why I'd have chills, because my freaking temperature is 101, because it's trying to literally fry that bacteria in desperation, right? It's like, oh my God, just burn it all, right? There's a reason that we say, I'm going to burn it to the ground, because that literally is what our body does. So swelling and bloating of the abdomen, yeah, you bet it. It's mad. It's pissed, guys. It's literally just running around. It's rearranging furniture. My dad, God love that man. He was so funny, and he didn't speak audible English very well. I had to translate a lot. And one of the things that he would say when he went into a hospital, because he hated hospitals, he had to go in there one time for his mom. She was really sick, my grandma. And he said to the nurse, because the nurse was really nasty. See, this is why I always talk about nasty nurses, right? And they didn't know my dad was like cold-blooded, right? Because my dad is like, oh, buddy, I tell you what, I am I am not my father's daughter, but I am my father's daughter, but totally not my father's daughter because that guy was, whew, he was legit. Anyways, so he looked at that nurse after she backsassed and he goes, "Lady, I'm about to rearrange this furniture." And when I heard furniture, I knew things were going to go swinging across the room because my dad was that guy. My dad was that guy that would grab a chair and throw it across the room because he was explosive and he was a wild cat. But I tell you what, it was only if you were hurting his family. He instilled that within me. And although I'm not going to instill that piece within you, I'm trying to instill this idea of protect your house, protect your tribe. You have to. You have to love them and nurture them unconditionally. Are they annoying? Yeah, for sure. Do they call you at random hours of the morning? They do. Is it ever important? Sometimes. But you don't care. You answer that phone, you suck it up, buttercup, because that's your family and you don't walk away from your family. Period, point, paragraph, end. Fin, okay? So let that be the last lesson I teach you for this lecture. All right, protect your family. Of course, know about post-surgical bowel perforation. I think I've explained that well. And remember, I love you. I'm proud of you. I'm excited for you that you're learning and you're trying. You got this. You are perfectly imperfect and there is nothing wrong with it. Dear Lord, no. That's the whole purpose of here. This is a sandbox. This is a training module, guys. Think about it. None of this matters. The only thing that matters is the lessons that are learned, right? Because matter can never be created nor destroyed. So where does it go? Where does it go? A little food for thought. All right, guys. Love you. Bye.